Okay, we're going to start in just one more minute. Just waiting for another couple of people to come in. Okay, good evening, everybody. So good evening and good afternoon, wherever you happen to find yourselves. My name is Jeremy Wimpheimer, and on behalf of Tzora Nevi Asrim, Tzora through 120, thank you for joining us for this program. Just to tell you, I believe many of you are familiar with Tzora through 120, but just to let you know, the service was founded a couple of years ago with the understanding that as people reach end of life or particularly challenging medical questions, they're often in search of support from social workers combined with halachic authorities. So our service brings that together and we answer questions from all over the world. The service is available both in Hebrew and English and is available 24/6 by calling *9253 or emailing us, and we'll be available to answer any questions. And that's one aspect of the service. And the other aspect of the service is to provide public information, which we're doing tonight through, this is now our third English language online seminar. And I'm proud to open the session. Tonight, we're going to be discussing the issue of helping and addressing patients and loved ones that were with dementia and memory loss through the ethical, medical, and halachic perspectives. Our panelists this evening are Rabbi Yuval Cherlow, who is the director of the Tzora Center for Jewish Ethics and the founder, one of the founders of the Tzora Rabbinical Organization and of Tzora Nevi Asrim. And he will be joined by Dr. Shelley Sternberg, who's the director of the Memory Clinic at the Shaare Zedek Medical Center in Jerusalem, and is an expert in geriatrics care and treating memory loss and helping people with memory loss in general. She also serves as the director of geriatrics in the Maccabi Health Fund in the Jerusalem and Shfela regions. So our program is divided into two separate sessions. Dr. Sternberg will go first in both sessions. And at the end of each session, we'll take questions. Your questions should be posted in the chat and we'll try to get to as many of them as possible. And with that, We're going to open the program. The first session is a general overview of medical and ethical challenges in treatment of people with dementia. And again, any questions should please be posted in the chat, and we'll get to them at the end of each session. And with that, I'm honored to call upon Dr. Sternberg.
Thank you very much, Jeremy, and thanks for everybody who's joined us tonight. I apologize in advance. I'm actually in quarantine at home with COVID. So if my voice is a little not as strong as it usually is, you'll forgive me. I'll do my best. Okay, so I prepared a slide PowerPoint presentation, so bear with me here. I'm just going to share a screen and pull it up. Okay, can everybody see that?
Yeah. Yes.
All right. So I'm going to give a general overview of dementia. I'm going to, sometimes I'll say Alzheimer's disease, sometimes I'll say dementia, and you'll see what I mean as we go along. So what are we going to talk about? We're going to talk a little bit about what the normal changes of aging in cognition are. We're going to talk about what is dementia. We're going to talk about how we can reduce our risk to get dementia. And then we're going to talk a lot about different modes of treatment. So here we go. So this is a 72-year-old woman who comes to our office, and she says, "Doctor, I'm forgetting names. I go into the kitchen and I can't remember why. And sometimes I have a word on the tip of my tongue and I just can't remember." And then she looks at me with a horrified look and she says, "Do I have Alzheimer's disease?" So the most important fact I kept from you, which is that this woman is still working. She's a psychologist. She has a private practice. She had her family over on the Chagim. She still drives. She still cooks and cleans and is fully independent. So we'll get to it in later slides, but one definition of dementia is that the cognitive problems have to impact on daily function. So by that definition, she can't have dementia, and I tell her that. But she says, "But doctor, it's really bothering me. I have patients who are sitting in front of me. I've known them and I've taken care of them for years, and then all of a sudden I forget their names." So what does this woman have? So she has normal changes of aging and cognitive function. So what are those normal changes of aging? So again, there's normal changes of aging in every structure in the body. Our hair gets gray, the skin has changes of wrinkling, kidney function changes, cardiac function, heart function changes, and so too brain function changes. So thinking is a little bit slower. People become more easily distracted. They need more hints, and they have trouble remembering names. So although it's annoying, trouble remembering names, like this woman is complaining of, is really not a symptom that would make me worried. And what we recommended to her is that she contact the occupational therapist in her Kupat Cholim, in her medical practice, and sign up for a course on learning strategies to improve your short-term memory. Okay. So then 2 years later, she comes back to my office with her son. And her son this time says, "Look, I'm a little more worried about my mother. She seems to be forgetting her medication sometimes, and she's not paying her bills on time. And so I'm a bit more concerned. Is there something else going on here?" So of course, we do a full physical exam. We do blood tests to make sure that there isn't some medical problem going on. We do formal cognitive testing. And unfortunately, it seems from all these assessments that she does have a memory decline. She also has a decline in at least one other area of cognition. What does that mean? What's another area of cognition? It could be language, it could be orientation, could be planning and organizing. So she's forgetting to take her medications and she can't get organized to pay her bills on time. And these cognitive problems are leading to decreased function, just as we've described. There's no element of delirium or other cause. By delirium, I mean, and we'll discuss it later, by delirium, I mean like a more reversible or acute onset of confusion. Someone is hospitalized, an older person is hospitalized, they're sick, and they've never been confused before, but when they're in hospital, they're confused. That's delirium. So this woman hasn't had hospitalization. She has no other medical problem that's out of control, no new medical problem, no abnormal blood tests. So she has dementia. There are many types of dementia, just like I like the way one of the speakers in the other talks that have been given before, Donna Pear, she describes apples. There's a whole class of apples, but there's many different kinds of apples. You can have yellow delicious, you can have Macintosh. So too with dementia. When you say dementia, it means a family of diseases. The most common of these diseases is Alzheimer's disease, but there are many other dementias, like vascular dementia, which means mini strokes, Lewy body dementia, which is related to Parkinson's-like symptoms, et cetera, et cetera, et cetera. For the purposes of this discussion, we're usually going to be talking about Alzheimer's dementia. I'm going to use Alzheimer's and dementia, use the words interchangeably. So how do we figure out what's normal aging and what's Alzheimer's disease? So if you forget what day it is sometimes and you remember later, well, that's normal. But if you're losing track of the date or the time of year, that's more worrisome. If you sometimes forget which word to use, or you have a little trouble remembering the word, but it comes back in a few minutes, that's normal. But if you're having trouble having a conversation or following the trend of a conversation, that's already more worrisome. If you're losing things from time to time, you don't remember where you put your keys, you don't remember where you put your wallet, this happens to me all the time, that's normal. But if you're misplacing things often and you're unable to find them or even have any sense of where they might be, that's already worrisome. So Alzheimer's disease, and I like to give this framework because it really helps families understand what they're seeing when their loved one behaves in a way that's unexpected. This framework of the 4 A's of Alzheimer's disease can be useful. So there's 4 words that begin with A that characterize Alzheimer's disease. So these are amnesia, agnosia, aphasia, and apraxia. And I'll go through each one. Amnesia is the most common. Amnesia is the most common. Memory loss, usually short-term memory loss. People will often repeat questions. They'll repeat conversations. They won't remember conversations. They won't know where they are. So this is the memory loss. As the disease progresses, it also involves long-term memory. Agnosia is something very important. It's the inability to recognize familiar things, places, or people. So often families will tell me that their loved one will come home from a day program, and when they get close to home, they'll start to get agitated and restless. This isn't my house, this isn't my house, this isn't my house. And this is agnosia. The person just doesn't remember. And sometimes what we say is just take your hand, walk around the block, come back and say, I'm really sorry, Safda, now we're home. So this can often lead to anxiety, but again, it's very important to remember, to know, to understand what you're seeing. Sometimes people with dementia will get mixed up. They'll think that their spouse is their mother, or their son-in-law is their father. So again, that's agnosia. Aphasia is language problems. So sometimes people with dementia will replace one word for another word. They'll have trouble following conversation or making conversation. People with dementia, people with Alzheimer's disease actually have a special kind of speech that sounds like this. Well, I went, very nice. In other words, there are words there, but at a certain point, the words don't have any kind of logical flow. And then apraxia is an inability to coordinate purposeful movement. And this has a real impact on daily function. So sometimes people won't recognize anymore how to brush their teeth because they don't recognize what to do with the toothbrush. They won't know how to use their cutlery. And as the disease progresses, it affects also gait and walking and coordination, and they may have trouble with steps or curbs. So I like to keep this model in mind. I find it really helps families understand what they're looking at, and most importantly, to understand that some of these unusual behaviors are not dafka, they're not doing anything to get back at me. This is the disease that's talking. So if we look here on progression of symptoms in Alzheimer's disease, if you see here along the x-axis, it's progression of Alzheimer's disease in years. And along the y-axis is deterioration. In other words, the higher we go on the y-axis, the more deterioration there is. So initially, there's sometimes just mood changes. The people understand that something's not right, but they don't know what exactly. And then there's impact on cognitive function, and then impact on daily function. In the moderate to severe stages, there are behavioral problems. And then in the end stages, motor function is also impaired. So people will have trouble walking, speaking, swallowing. And Alzheimer's disease is a terminal illness. We don't like to think of it that way, but if people don't die of heart disease or cancer, they will in the end. And a terminal or advanced dementia is a state where a person is bedbound, needs help for everything, doesn't recognize their family members, speaks only 3 words. And Susan Mitchell, who came and spoke in Israel a few years back, did the groundbreaking study where she followed 250 nursing home patients in the States who met these criteria, and she followed them for 18 months. And after 18 months, 55% of them had died, 90% of them had eating problems, and most people got into trouble with pneumonia because of swallowing problems. So can we prevent dementia? So a recent study that came out in 2020 in the Lancet, which is one of the most respected medical journals, showed that if we control these 12 dementia risk factors, then on a population basis, we can decrease the risk of dementia by 40%. That's unbelievable. So some of these risk factors would be familiar to us because what's good for the heart is good for the brain. So if we don't smoke, if we control our blood pressure, if we control our diabetes, if we control our weight, and if we're physically active, then those are the risk factors that we know already that can decrease heart disease, but they also decrease dementia. In addition, there were some other risk factors identified that were less known. Treating hearing impairment is a very important risk factor. Social contact and treating depression, limiting exposure to air pollution and in young ages, preventing head injuries in education, and limiting alcohol consumption. So these are 12 risk factors that can make a difference on a population level. So what would be some practical suggestions to each one of us to decrease the risk of dementia? So first of all, starting at age 40, control your blood pressure to 130/80. Treat obesity and diabetes, exercise regularly, and make sure you have social stimulation. Exercise regularly means 150 minutes a week of good walking. What does that mean? It could be 30 minutes 5 times a week of really good walking where you get your heart rate up, or the equivalent. Exercise is good if you do it and you like it. You can do 15 minutes twice a day too. You can do 2 hours once a day and 30 minutes the next day. The recommendation right now is 150 minutes a week. Stop smoking and decrease use of alcohol. We know that stopping smoking, even in mid or late life, can decrease risk. Treat hearing loss, go get your hearing tested, use the hearing aids, it can decrease the risk, and decrease exposure to secondhand smoke and air pollution. So in terms of treatment, there are many, many different avenues of treatment. First of all, setting up an appropriate schedule of activities. Regular schedule is very important for people with dementia. It gives them a feeling of security. Supporting caregivers, whether it's in groups, one-on-one, and just the personal care that's needed as the disease progresses, whether it be bathing, dressing, or so on. Very important early in the disease while the person can still say their wishes, that advance directives being filled out, healthcare power of attorney, living wills, very important while a person can still discuss what their wishes are. And again, I want to get back to this issue of delirium. Dementia doesn't progress from one day to the next or from 1 week to the next. Unless the person's had a stroke, dementia progresses very slowly over time. It's a hint to family members that if the person is more confused today than they were yesterday or than they were a week ago, the address is the family doctor. First of all, think about medications. Are there any new medications? Some of the cold medications that are used at this time of year have components in them that can make a person with dementia more confused. Is there a new medical illness? Even a flu or a bladder infection, UTI means urinary tract infection, can make a person with dementia more confused. Is there a change in the environment? Even if the usually caregiver goes on vacation, or if it's a holiday and there's no regular schedule, all those things can make a person with dementia more confused. Okay, there are also medications. Oops. Sorry. Okay, there are also medications that are used in Alzheimer's disease. These medications do not stop the disease, but they can slow down progression, and it's something that needs to be discussed with the treating physician. So I use these medications very frequently. They each have their own side effect profile, but they definitely have a role in the treatment of people with dementia. And also an important area in treating of dementia is challenging behaviors. So here we have an 87-year-old woman with dementia for the last 6 years. She's dependent in all her activities of daily living, including bathing and dressing, and her family reports that she's aggressive. So I like this framework called DICE. Describe the problem, investigate the problem, create a plan, and evaluate. So describe the problem. I asked the family, what do you mean she's aggressive? Is she kicking, biting, screaming, pushing? What does she do? So they say she just raises her voice. And investigate what could be a cause. So it seems to always happen around bathing in the morning. So create a plan. Well, maybe we don't need to bathe her in the morning. Maybe we can involve her more. Maybe we can turn on the shower in advance and let her smell and hear and get her ready. And then evaluate to see if it works. And if it doesn't work, then to think of other ideas. Here's some helpful phrases. Never go head to head with a person with dementia. Try to get inside their head and see what they're trying to express. So some helpful phrases are, can you help me? Will you give it a try? Would you like this one or that one? And I'm sorry this is hard. We'll get through this together. So it's also very important for a person with dementia to make the environment less cluttered and more conducive. In this picture, you can see that even it makes me feel overwhelmed looking at all the clutter and all the false risks on the floor. Try to make the room with like a call center in the middle, a control center in the middle, put all the books together and make it more understanding. And the last point I wanted to bring is that technology is starting to, the tech people are starting to be very interested in helping people with dementia. Here are just a a few things, an automatic little device to find your keys, a pill box that talks to you, a clock that helps a person with dementia know if it's day or night. So this is, I think, a new and exciting development to figure out how technology can help. So in summary, normal changes in cognition include forgetting names. Dementia is not a normal part of aging, is not contagious, and is usually not genetic. Dementia is defined by cognitive impairment that impacts on daily function. We talked about the 4 A's of Alzheimer's disease, which are amnesia, agnosia, apraxia, and aphasia. The risk of developing dementia can be reduced, and we talked about the 12 ways. Timely diagnosis is important to initiate treatment, and the treatment, as I just gave you a taste, is multifaceted, multidisciplinary, and includes caregiver support and education, advanced care planning, daily routine, management of challenging behaviors, medications, and more. And here, if anyone would like to get in touch with us at the Shari Tzedek Memory Clinic, these are this is how you get in touch with us.
Thank you very much, Dr. Sternberg. We're now going to turn to Rav Cherlow, Rav Cherlow will be offering a perspective focused more on the halachic and ethical aspects of coping with loved ones with dementia. So with that, Rav Cherlow.
Shalom, everybody. I'm apologizing that I speak the most common language in the world, and that is lousy English, but hopefully everybody will understand me, and I may use a few words in Hebrew. Every situation in life has a lot of aspects, not only medical aspects, but also ethics and halachic aspects, and humanity and mercy and whatever, all kinds of aspects that the situation has. And Alzheimer, because it's a long, can take years and decades, from the beginning of Alzheimer until the end of it. And it has a lot of aspects. What I want to do this evening is to demonstrate at least 5 fields of halachic and ethical questions, some answer, only to have the taste to understand what we are dealing with, and actually what we are doing in Zohar at 120 until 120, dealing with all those aspects and all those questions about Alzheimer. So as I said, I'll speak about 5 fields that are related to the situation when one of our family members is being identified with Alzheimer, and we are starting our a very, very long journey together with him. The first aspect is the environment, the field, because we are the parents into a concentrate of taking care of the person that Alzheimer in our house. What is the because we are still taking care of them and they have their needs in our couple, I mean, my wife or husband, in ourselves. Does the halacha and the ethics recognize the fact that we have our needs? And there's a very important Mishnah in Baba Metzia that says that avidato va'avidat aviv, if my father lost his wallet and I lost my wallet, whose wallet is first and what to search for before the second wallet and the other wallet? And the answer, surprisingly, is avidato kodemet, because the halacha says that there are needs of a person and we recognize them, and not everything should be dedicated and being all concentrated on taking care, even though the kibud avayim is something that is very important. But we have to remember and have to balance between all our commitments and even the commitments towards ourselves in this situation. That is only one example, talking about the environment. There are questions about, must I make a bikur cholim to my parent that actually doesn't know even that I was there. So is there any kind of halacha and ethical and humanity approach towards those questions? Let's say that I know that my wife loved this house and said, I don't want to move from here. I want to stay here and I want to die here. But she's not with us anymore. I mean, all her knowledge is not with us, and it will be much easier for me to move to live near our kids, and then we can take care better in a better way, and I can get assistance and help from my children. So these are all kinds of questions that are talking about the person that has dementia and is surrounded by the whole family and everybody that actually the consequences of this situation, and that is being influenced by the fact that we have someone in our house and very close, I mean, parent or whatever, but we have other people and we have to balance all our commitments towards everyone. Second field I want to speak is mitzvot, commitments. I'll start with a story that we had, that one very good friend of us has asked us. I discovered that my husband doesn't recognize even that he didn't lay tefillin. He doesn't have any connection to this. So I stopped laying tefillin on his arm. So a day or 2 days later, the foreign worker called me and told me that he worked before in a Haredi family, and they laid tefillin for 25 minutes on the hand. And why? He really asked me, and he was very annoyed that I'm violating the halacha commitments, and I should put the tefillin, he said, the foreign worker, on my husband's arm for 25 minutes. So this is maybe a funny question, but actually there are a lot of situations. Should I force him to lay tefillin? Should I force him to lulav and sukkah and fast on Yom Kippur? And Hanukkah is soon, so what to do with Hanukkah candles? And that are what we call mitzvot aseh, things that you have to do. But there are also a field of mitzvot lo ta'aseh. He relaxes when he lights the television and turns it off. Can he do it on Shabbos? Can I give him the shlak, the remote control, in order to do that? And especially, it's more common question from the abroad. We have a very good institute that near our house that can take care, and he can have there a very good time, but it's not Jewish, so no kosher food and violating Shabbat. So what halacha? As I said, I want to say only one thing about the answer. When we are talking about doing things like tefillin, the idea is that if he cannot do it by himself, I mean, he cannot make his freedom of decision if to do it or not to do it. So actually doesn't have any value when we are forcing him to do the activity, but he's not there. Now, sometimes it's better to do that, but not because of halachic reasons, because of treatment reasons, that he'll feel part of the family, be in the Seder, eat matzah, but to force him and that he will suffer from it, this is not according to halacha. And that's only one example of what I call the halachic field of having someone with dementia in our family. The third field, I want to say another thing about the mitzvah. It's not only he or her observing the mitzvah. It's also questions about us. Let's say my mother is calling me constantly, every day, even on Shabbos, because she doesn't know it's Shabbos. And If I'm not answering, she gets nervous and annoyed, and sometimes she loses control. Can I answer the phone in order to make her relaxed? And it's part of the treatment on Shabbos. So these are also questions that are related to the halacha aspects of dementia. The third field is honoring, and it's from the beginning. When and how should we call that transportation office and try to avoid his driving or her driving, and that I don't want to be insulted, that he will be insulted, or he will feel that someone actually made a very aggressive activity against him because he thinks he can continue to drive. But what should we do? So this is a medical question. It's not a rabbinical question about the ability, but the rabbinical or the ethical question is how to do it. Should I do it directly? Should I try to convince him? Whatever. What to do with very strange behavior? Sometimes dementia is being identified by aggressive behaving, not by falling into yourself, but yelling and losing your self-control. What to do? Can I hug him very hard? What to do with the kids, our children, that are seeing Sabbath and Sabbath in very difficult situations? What take care of him when there's need to use a little bit of power, or it's better that the foreign worker or someone else, a nurse or whatever, do that, and all kinds of those questions that are related to to honor him. For instance, we'll have soon the Seder, not soon, it will take a few months, but where should he be and how can I honor him in the Seder in the same time that the Seder is taking place and the children are part of it and the whole family. So this is the third field. The fourth field that many times we don't see it as a field, but it's a great issue, and that is lie and truth. Because I'm not talking about the very typical question, should I explain his situation? Should someone that is ill should know exactly his situation, or can I hide things? But when we are dealing with dementia, it's much asks, where is Hannah? And Hannah was here 10 minutes before, or maybe she didn't come today, but if he'll get the right answer, she's not coming today, he'll get very angry. So therefore, I want to answer, she is here, she'll be in 10 minutes, and in 10 minutes, he'll forget the question. And this is actually saying something that is not truth, but it's good for him. Now, this is a big issue regarding many aspects of halacha. Some of you are probably familiar with the halacha and the sugya and the Gemara that deals with the question, what do you do when you come to a wedding? But the kala is not na'ava chasuda. And the paskan of Bet Hillel that said that even though every kala deserves kala na'ava chasuda, because you are permitted to say something that is not exactly the truth in order to honor her and in order to make her happy. Can I use this sugya and say the same thing with someone with dementia? That means that if truth and lie doesn't mean anything anymore, and he doesn't have the ability to distinguish between them and to be affected by those facts. So maybe from now on, we are permitted to say everything that according to a different factor. It's not if it's truth or lie. The question is, does it make good things to him or bad things to him? and something is completely changed. But don't forget that saying the truth is a very, very important pillar of Yahadut. The Mishnah says, Al shlosha dvarim ha'olam omed, the world is standing, and emet al adin vel shalom. So therefore, there are halacha questions that deal with the question, with the field of saying they are lie and truth, and I gave only one example of the answer that is being based on the sugya of how to dance in front of the kala. Finally, I want to speak about finance aspects. The halacha actually surprisingly says that, first of all, to finance the treatment of our parents, especially when we're talking about dementia, is from their money, not from mine. Mishel Av, as the sugya says, and that's something that is very important for us because we have a lot of expenses when someone with dementia is living with us. But they're very, sensitive questions about using their money. For instance, we got a question in Zohar Ad Me'av Esrim that a family grandmother used to buy to every child when on his birthday a present, and she used to spend approximately 200 250 shekel for the present. Now she's not, her knowledge is not with us anymore. Are we permitted to continue this custom? And even though it's her money, it's not ours, but say to ourselves, because she did it, and probably we assume that she wants that every grandchild will get a present for their birthday, so can we continue to use her money and spend it not for her needs, not for having good treatment towards her or feeding her or medicine or whatever, but giving this present representing her with those presents. So this is another field of ethics and humanity. What I want to say actually is that we have two levels of discussions. The first one is the terrific presentation that we heard before, what to do medically. But we have to get used to that we have a let's call it floor of questions, and that are ethical and halachic issues that from now on, once we have someone that we are responsible for him with dementia, then we have to ask ourselves all those special questions, and we have some answers. And that's actually what we are doing in Zohar Ad Me'av Esrim.
Excellent. So, Rav Cherlow, one question we've gotten, a lot of people are asking if there's any way to improve the connection. I don't know if you can move somewhere or anything, but we got 95% of it, but it went in and out every now and then. So if there's a way, but I understand it might be difficult. So let's get to, there's a couple of specific questions for Dr. Sternberg. There was a recent study showing vitamin D levels were able to impact risk for dementia. What are the current recommendations? You're muted. Okay.
So the current recommendations don't include vitamin D for dementia prevention. The data just isn't strong enough yet to include it as a recommendation.
Okay. Excellent. So another question for Rav Cherlow. It's a general question about what halacha and ethics say about the rights of people with dementia to have full equality and full integration in society after being diagnosed with Alzheimer's or dementia.
If we are talking about rights, so to have the right, most of the questions are under two situations. first one, if they must to do that, and that's the first thing. The second question is, what's happening when it disturbs the society, and they're coming to shul, but they are yelling and moving and disturbing everyone else. So this is a very sensitive question. I can say in general, we should try to have as much equality, and that the person with dementia will participate with us together, because he's a human being, he's a person, he has his identification, and so therefore, as much as we can. But as I said about the family and in the beginning, boundaries. You have to balance between the rights of everyone else and to try to find a situation where his participation is not avoiding and is not really dismissing the society enjoyment or davening or whatever. So, as I said, he has the right.
What?
We have to balance it, and we have to ask if he must do that.
Thank you. Dr. Sternberg, another specific question. Can adult ADHD cause memory loss in seniors that mimic the symptoms of Alzheimer's?
That's actually a great question. So it's not a lot known. ADHD usually causes problems with attention and focus, not so much memory. So it's usually a little bit of a different picture cognitively. But we do always ask people, are these cognitive problems new? Did you have trouble in school? Is this something you've been dealing with for a long time? So, there is some overlap in symptoms. I don't think we know yet if ADHD causes dementia, but the cognitive picture is a little bit different than what we usually see.
One just technical question. I think that you mentioned at the beginning, dementia and Alzheimer's can be used somewhat interchangeably. Is that correct, or?
Well, no, what I said is that dementia is like apples, and there are many, many different types of apples. There's Golden Delicious, there's Macintosh, same thing. Dementia is a basket of diseases, of which Alzheimer's is the most common one, but not the only one. So I just said, for the purposes of this discussion, the terms would be interchangeable, but no, they're not the same thing.
Okay, excellent. So I think we're going to move on to the next session. There was some request, if Dr. Sternberg, if your slideshow, in addition to the video, might be available, if you could upload it or so we can send it out. There was some request for that as well, if that might be possible. So now we're going to move on to the second session. The second session takes us on a bit more of a targeted route to discuss the issue of assisted feeding for people with dementia. Once again, Dr. Sternberg will address it from the medical perspectives, and then we'll turn to Rav Cherlow for the halachic and ethical perspectives. So Dr. Sternberg, thank you.
Okay, so thank you very much again for this. Really required me to put together a new, it's a topic that is close to my heart, very close to my heart, but it did require me to put together a new slideshow, so here we go. Okay, can everyone see? Jeremy, just tell me we're okay.
Yep, we're good to go.
Okay, so we're going to talk about why are there eating challenges in dementia, and then we're going to spend a fair bit of time at the end talking about feeding in advanced dementia. So I would refer anybody who's interested in this topic to this wonderful brochure that was produced by the Ministry of Health, EMDA, which is the Israel Alzheimer's Society, and the Joint Israel. I put the link there, and a lot of the information that I'm presenting can all be found in this booklet. So why do people with dementia have eating problems? So it depends on the stage. Certainly in the initial stages, there's sometimes some depression and social isolation. Again, when people have a feeling that something's wrong, but they don't really know exactly what's going on. There's medical problems. People have dry mouth, they have poor fitting dentures, they have teeth problems, they have pain because they have sores in their mouth, they have some kind of new illness. Again, any kind of new illness, even the flu, can take away people's appetite, especially somebody with dementia. Medications can impact on dryness in the mouth and appetite. Constipation is very common in older people and also even more common in people with dementia. And as the disease progresses, the worsening cognitive and motor problems lead to even more problems with eating. People have apraxia of chewing and swallowing, so they end up holding food in their mouth. They sort of don't know how to swallow anymore. So many reasons for eating problems in people with dementia. So to actually eat properly, you need to buy the food, prepare the meal, organize the environment, and then get around to eating. So if we go back to the son from our previous presentation, he came in with his mother for follow-up and said, look, I'm getting a little concerned because I went to visit my mom and I found spoiled food in the fridge. What should I do? So we said, go on a shopping trip with her and see how things go. So he found that shopping takes her a long time, that she had trouble following the shopping list, that she was buying multiples of things. She had 3 margarines at home, she bought another 7, and she had trouble making change. So what would be some tips? Some tips would be go to shop together or shop together online. Give her a set amount of money, and whenever the family comes to visit, check the fridge regularly, take out spoiled food, make sure that there's good fresh food in there. So if we look at preparing the meal, this son, who's very dedicated to his mom, said, look, I'm going to cook with you, Mom. Let's make a meal together. And he realized that the wonderful challah recipe that she used to make, she couldn't remember how to do anymore. She was leaving pots on the stove, and he was beginning to get worried that she just wouldn't be able to cook anymore at all. So again, some tips would be prepare together. In other words, the son could make the dough for the challah in advance, and then she could get involved and do the braiding. When making a salad, she could take the vegetables out of the fridge. But the son could do the chopping. Set an alarm when things are put on the stove, and organize the kitchen in a way so that everything is very accessible. Organizing the environment. So the son also noticed when he was trying to cook with his mother that she had trouble using the utensils. As we said, she had one of those A's, apraxia. She had trouble coordinating the movement of how to use the different utensils needed to prepare the food, how to use cutlery. Her meal times were getting very disorganized. She was forgetting to eat and then eating at strange times. She liked to eat in front of the TV more than in the kitchen, and she had trouble cleaning up, so the son would come and visit and the kitchen would be a mess. There would be dirty dishes in the sink. So again, some tips would be prepare labeled meal packages that say on them breakfast, lunch, and dinner. Have them in the freezer or in the fridge. Make sure the eating area is free of obstacles. It's okay if she likes to eat in front of the TV, but make sure that that area is comfortable, that there's no cords for her to trip on, and bring in some help to clean up. Also, it's very important to have an environment, as we said in the previous picture, an environment that's conducive to a person with dementia. I wouldn't want to eat at this table. I don't know how you feel. Look at this. This is how a table for a person with dementia should be set. If you can see, there's high contrast in colors. It's very easy to see where the plate starts and the placemat ends. The cutlery sticks out very much, and the different food groups are very clear. So all these contrasts really help a person with dementia and perceptual problems. It helps them, eat more easily. Then if we get down to the actual eating, there's all kinds of eating challenges themselves. Some people with dementia eat too little. Some people eat too much. They don't stop eating. They think they haven't eaten yet. Some people eat mostly sweets. And then as the disease progresses, there's choking or coughing during eating. So what might be some tips when a person's eating too little? We have to check, are they forgetting to eat? We also have to assess their teeth, their mouth, make sure they don't have constipation, and offer finger foods. Just put finger foods out around the house at all times, so whenever the person feels hungry, they can eat. Referral to a dietitian to make sure that the food they do eat is high in calories. A person can eat too much, again, just like they forget to eat, they forget that they've eaten. Their sense of hunger and being full becomes a little off. In addition, there are some medications that are used to treat behavioral problems that sometimes can increase appetite. So food should be sealed in the fridge. There should be small, frequent meals. This would not be a person that you would want to leave finger foods out and about. For whatever reason, I don't know the reason, but people with dementia like to eat sweets, and families sometimes get concerned, especially in diabetics. So again, small quantities of sweets are okay. Sometimes you can try to substitute sweet fruits, but it is sort of a symptom of dementia. And as the disease progresses and the swallowing mechanism and the motor function in general, start to be affected, a hint for families that they need to get a speech and language pathologist involved and a dietitian involved is when the person starts to choke on their food or cough where they're eating, especially when usually it happens first when they're drinking what we call thin liquids like water. And there is thickener that can be bought in any pharmacy that can be added. It's kind of like potato flakes, and it doesn't really affect the taste, but it thickens up the liquids, so there's less risk of choking. In Israel, it's called thick and easy. So this is just some examples of finger foods, obviously Israeli finger foods. You can also put out rice cakes or, things that are healthy and easy to eat by hand. Just noting here that in order to avoid constipation, the diet needs to have fiber in it, whole wheat breads, for example, and some vegetables. You have to make sure that the person with dementia is drinking adequately. Again, as a normal change of aging, people don't feel thirst to the same degree that they do when they're younger. So we need to make sure that people with dementia are drinking adequately, and again, go to the doctor and make sure that there aren't medications that themselves are causing constipation. So if we're going to talk about the problems in advanced dementia of the choking and coughing while eating, again, I'm putting up this slide again to remind us that advanced dementia are people who are bedbound, don't recognize their family, don't speak more than 3 words, and need help with every activity, bathing, dressing, everything. So 90% of these people have eating and swallowing problems, and they usually get in trouble if the food goes down the wrong way, ends up in the lungs, and then they have what we call aspiration pneumonia. So this is the time that when people have had, let's say, 1 or 2 aspiration pneumonias in the last 6 months, and there's, recurrent choking and coughing, that the issue of feeding tubes is raised. So I wanted to just describe what is a feeding tube. So a feeding tube is a PEG, a percutaneous endoscopic gastrostomy tube. Basically, a doctor will go in with a scope through the mouth down into the stomach, will light up where the stomach is, and then another staff member will make a little hole through the skin and go right through the stomach, put a tube in there, blow up a balloon so the tube stays in, and then the tube comes out of the stomach wall, as you can see in the second picture, and liquid food is connected to that tube. So what does the evidence say about tube feeding? I think some people are going to be surprised by what I say. So please bear with me. So these are all studies done in the United States on nursing home patients, and tube feeding in people with advanced dementia. Again, the people that I said who are totally bedbound, don't speak, don't recognize the family. Tube feeding has never been shown, does not prolong survival, does not improve nutrition, does not prevent aspiration pneumonia, and does not improve wound healing. And it has downsides. Number one, it's a procedure, albeit a minor one, but it's still a procedure. Number two, it can lead to disturbances in the metabolism or the metabolites in the body. It could sometimes require that the person be restrained or tied down because they sometimes pull out these tubes, and they can often lead to less one-on-one time because the person is just fed through a tube. You just hook up the tube and you can leave. The American Medical Directors and the American Geriatric Society and the American Academy of Hospice and Palliative Medicine recommend against inserting percutaneous feeding tubes in individuals with advanced dementia and recommend hand feeding. In the Netherlands, this putting in a feeding tube is not even offered for people in advanced dementia. It's like giving antibiotics for a viral infection. It's not considered a therapeutic intervention. In the United States, it depends on what state you live, whether you'll get a person in this advanced dementia will be offered a feeding tube or not. But, so given this evidence, why in Israel do we still have a lot of people who get feeding tubes? And I put here a broken heart because many families will come to me and say, what, I'm going to let my mother starve to death. She's a Holocaust survivor. Food has always been very important to her. It's a sign of love. How can we do that? So I just wanted to say here that we can't ask people in this state of advanced dementia if they feel hunger or if they're suffering because they don't have the ability to speak to us. But we do know from people who have end-stage cancer that they don't usually feel hunger and they don't suffer, that the body is just closing down. And as the body closes down, it needs less nutrients. So careful hand feeding is recommended. And again, this is something that a speech and language pathologist with experience in swallowing problems and a dietitian can be very helpful to teach the family. The person needs to be sitting up. They need to be alert. This needs to be done multiple times during the day. You have to wait for the person to swallow before giving the next feed, but it can be done. And soft and nutritious foods can be given. Again, this is where the dietitian can help. And there are many techniques that the speech and language pathologist can teach to encourage swallowing, like massaging the cheeks, stimulating the palate with high tasty foods like warm foods or spicy foods, giving verbal cues. Okay, it's time now to swallow. You're doing really well. And as we talked about, thickened fluids can also prevent the choking and the coughing. So in summary, there are many reasons for eating problems in different stages of dementia. There are also many tips that I just gave you. The tip of the iceberg on these tips can be very helpful for supporting independence in preparing food and eating. And eating problems in advanced dementia are very common and require a multidisciplinary approach, of course, including a halachic authority. Again, this is the information. In our Shari Tzedek Medical Center, we have a multidisciplinary team. We have a nurse, geriatricians, occupational therapist, and a neurologist and a psychiatrist when necessary. And we do a very holistic assessment. Thank you very much.
Thank you. And we'll turn back to Rav Cherlow for the halachic and ethical aspects of this conversation.
Shalom. First of all, I'm apologizing about the quality of the connection. I tried to move to another network and I hope it will work better. The feeding is the most sensitive ethical and halachic dilemma, because it's not only from the feelings and emotional, because this we can face. The problem is that when the halacha was written, I mean, a few years ago, every rabbi wrote that feeding is part of the things that you must do. Even the rabbis that said, according to halacha, and that actually these are our recommendation, that you can, if there's a need to ventilate, sometimes you can say, no, we are not ventilating, and we're not doing anything, and a person can die. We don't have to give a special surgery or whatever, surgery, but there are things that you must do, liquid and feeding and antibiotics or whatever. There are few things that you must do that. But in the recent years, in the last years, we heard from many doctors, and I can say even most of them, that this is a wrong approach, because many times, especially when there is a very deep dimension, as we heard before from Dr. Shelley, feeding is not helpful. Feeding causes a lot of pain, a lot of suffering. Feeding is dangerous because many times the patient can try to pull out the tubes. And actually, we're asking ourselves as ethical people and halachic people, we're asking ourselves if this is the right approach and this is the right recommendation to say that under any circumstances you must feed. Especially when the doctors, when the medicine professions say that this is the wrong thing to do. And there is a point that actually you don't get any benefits from continuing to feed, but you get a lot of dangerous things, and you do things that are really harming and disturbing and a lot of pain and a lot, as I said, suffering and dangerous activities when you are continuing to feed. So as long as it's possible to feed without artificial feeding, I mean to feed with a spoon, and to learn how to do that with dietitians, with a special clinic professional and whatever, and you have the time and the patience, and you can distribute this function and do that, make the responsibility to do that, to share it with more members of the family. This is the right thing to do, but you have to be very dangerous that the food would not come into the lungs. But when this is not impossible anymore, and the doctors say that it's actually there are no benefits, this is the time to really consultate and ask ourselves if this is the right thing to do, and to try to feed them, to force feeding by artificial feedings, all kinds of ways, what we call zonda, what we call tube, what we call peg, what we call all those things. And our approach is that as long as it's possible, really feeding is, you must continue it. We don't know if what is the suffering from starving, but there is a point where the balance between the benefits of feeding and the damage and the suffering that the feeding can do, there is a point that from now on, the right thing to do is not to feed. And professions say that the patient can remain and it's not only survive, can continue. Definitely, if it doesn't move, if it doesn't have any connection, if it doesn't actually need a lot of calories and all the other things for a long time to continue living without having, as I said, damage and suffering. Now, every case is different. And this is something that you cannot say in general. We have objectives, pillars or objectives, ideas where we can say that this is the time to stop feeding or not. But once the family and the rabbis and the ethical advisors know that there is a point where feeding is not the right thing to do, then we have the freedom of testing and asking ourselves and analyzing and questioning if we reach this point or not. But until, as I said, we discover that, and as long as we think that feeding must be done under any circumstances, from my experience, we do more damage than help, more pain than avoid suffering, and actually we're not doing the right thing. So the most important thing that I wanted to emphasize is that as long as it's possible with the family, this is the right thing to do. But when you reach this point, you have to check and to be very, very careful with the decisions and try to feed as long as it's possible, but not to do things that actually are making ourselves relaxed and feel that at least we are doing the right thing, but actually we're doing a lot of damage. What we are doing at Be'av Yisrael, we are asking the doctors, we have questions, I think the right questions to ask the doctors. Doctors will not give an answer, how long will this patient live and when is the death expected or whatever, and these are wrong questions. But when we ask, will you be surprised if he will not survive for a month? Or will you be surprised if he will survive more than a month? So this is a kind of a question that you can know what actually are the expectations and what is the future broadcast, I'll say that. I mean, trying to understand what is going to be. And then every patient must have a separate discussion and a separate decision about the question if to continue to feed or not. I want to emphasize that I'm talking about food. I'm not talking about liquid. That's, for no doubts about that you cannot make the patient dry out and whatever. But when we are talking about feeding, our message is to have two stages. The first one is to try with the family, as we heard before, feed in the natural way under special instructions and restrictions and understanding how to do that in order to avoid damage. And when it's not possible anymore, to consultate and to discuss together, the family, the advisors, the doctors, the staff, what is the right thing to do, and understand, we as families must understand that there is a point that feeding doesn't help, is not helpful. And as I said, it causes damage and a lot of suffering. And so therefore we have to be very careful of trying to insist and to force someone to continue to eat. And I think this is a very important message and something that all of us must know.
Excellent. Thank you very much. So we're just going to finish with a couple of questions that we got. And if there's any last questions, feel free to share them in the chat. One general question that we got following the last session was, is or is not dementia genetically inclined?
So the most important risk factor for getting dementia is age. The older you are, the higher the risk of getting dementia. If you're over 90, your risk of getting dementia is 30 to 40%. If you have a first-degree relative in your family who has dementia, your risk is a little bit increased, but not tremendously. Having said that, there are some families that have genetic dementia. Those dementia on a genetic basis. There are specific genes like presenilin 1, presenilin 2. That's a minority. In those families, there's usually multiple people at young ages, under than 65, who have dementia. only about 5% of all dementias are specifically on a genetic basis.
Okay. So Rav Cherlow, this is probably a question that you've encountered in your experience. How do you advise individual families where the children may disagree on the correct care for a parent?
This is a very important question. Our decision or our policy is to make a lot of efforts in order to have a unified family. The reason is because in most cases, when you are unified, you get the right decisions. And second, what's more important is that you are avoiding really sometimes a completely damaging of the family after death, and continuing to argue if we did the right thing and not did the right thing, and a lot of pain so this is very important. And this is the reason that at 120, we are working as a team. When someone is calling our hotline and he wants advice, he gets advice from a rabbi and a social worker together. This is one of our, I'll say startups, that a rabbi with a social worker in order to, first of all, unify the family and speak with all of them and then come to the right decision. Now, how do you do it? I'll say it briefly because it's a long, it's a perception. But you do that, first of all, in the way of hearing everyone. Asking everyone what is his opinion, what he thinks that the parent wants to know. And in many cases, after your voice was heard and respected, and it's not a fight, it's actually together, it's a dilemma, it's not a conflict. And when this is the environment of the discussion, in most of the cases, it will take another day, another 2 days, sometimes like a lawyer. How far can you go? Or how far do you think we should go? Do you think we should continue to feed mother or father for 2 days, 3 days to see what's happening and then stop, and etc.? These are the techniques that we use, and it's a great success because the threat of tearing the family and actually destroying the continuation and the the tradition and everything that was good in the family is such a big threat that when you understand that we have to make a common decision and you're doing it slowly, and the first important thing is every voice was heard and was respected and was taken into consideration. And even if it will take a little bit more time, this is the right thing to do, and we have to do a lot of things in order to achieve this target.
Thank you. Excellent. Dr. Sternberg, a question. In an advanced dementia patient who cannot communicate hunger, can other factors such as weight loss be used to assess the need to provide nutrition via PEG?
So again, what I tried to say is that the PEG feeding, there's no data that shows that it actually improves nutrition. So, people with advanced dementia do lose weight, but the PEG doesn't solve the problem. It doesn't improve nutrition, it doesn't prolong survival, and it doesn't prevent aspiration. So, I agree that the person can't tell us if they're hungry, but I'm not sure that there are any other markers that would sort of force our hand as well in terms of making a decision about a PEG.
Okay. I think this will be our final question. When a person has dementia but is still somewhat aware of their surroundings, too much lack of control can lead to depression or even suicide attempts. What do you do to balance that, people who are still aware and without, treating them as if they're their children or if they're not in control of their destiny or their medical care?
I can take a stab at that. I would just say that I think that those early stages of disease are sometimes the hardest for the patient and the family, when the patient, as the questioner said, still has some insight. I think that the family just has to be very supportive, set up an environment that's very supportive of the patient, an environment where the person can still succeed. As we said, just as a feeding example, if the person doesn't remember the whole recipe, but the dough can be made together and then the person can be left to do the braiding on their own. So break down activities into smaller bites in a way that the person can still feel useful and meaningful, and that they have a purpose. So I think it's really about setting up an environment where the person can still succeed. Rav Cherlow, I'm sure you have something to add.
I completely agree. Every one of us must have a place and must feel that their existence is valuable and it has a kind of a potency. And therefore, as long as it's possible, this is the right thing to do. I completely, as I said, agree, absolutely agree.
Okay, excellent. Yes, a recording will be available. It will be emailed. The link will be emailed to everybody in the coming days, everybody who registered, and also on the Sohar's YouTube page. Just to remind everybody, any specific questions regarding family members or loved ones who might have specific questions can be referred to our service, which can be either the telephone here in Israel is *9253, or via the email address, which is ad120ad120@sohar.org.il. I put that in the chat as well. So thank you again to our panel, and thank you to all who joined us, and we look forward to having you on future programs as well. So have a good night and all the best.
Night. Thank you very much.
Thank you.
Thank you. Refuah Shlema.
Thank you.
Thank you very much, Refuah Shlema.
Thank you very much.
Thank you. Thank you very much. That was very helpful.
Yes, lovely session.
Yeah, thank you very much.
Thank you very much.